Hello, learners, and welcome to Med Learning Group's docuseries program. I'm Jane Seymour, and I will be your host for this CME activity. I've had the great fortune of being an Emmy Award-winning movie and television actress, which included my role as Dr. Quinn, Medicine Woman. As you know, success comes with hard work and lots of continuing education. That is why we are thrilled that you have decided to participate in this engaging, continuing education activity. Sometimes in medicine, one gets so wrapped up in the clinical, the pathophysiology, the diagnosis, the treatment, the research, that we forget what medicine is really about: the patient. We forget how unique every patient is. We forget that every patient has their own story to tell, and that each can teach us so much more than even the best PowerPoint presentation. Their raw honesty as they discuss their journey is something we rarely get to hear from patients during the typical 15-minute visit. We'll also have the great opportunity to listen to our program chair discuss all of the relevant data and practice examples to ensure you are optimally treating your patient. Well, this is going to be great. You have already engaged in the program, and we appreciate your responses to the tough questions. There's still a great deal to learn, so let's turn to our next patient.
My name is Dallas Miller. I'm 80 years old. I'm married, been married 52 years. I have 4 kids, 2 boys, 2 girls, 8 grandchildren, 4 great-grandchildren. We've lived in the Phoenix area for 5 years now. I first noticed I was having problems with my eyesight about 1.5 years ago. I was just watching a show on TV one day, and we have Venetian blinds on one of our windows, and I told my wife, I said, "Those blinds, do they look wavy to you?" And she says, "No," and she went and printed up an Amsler chart, which has grid lines and a black dot in the center, and she asked me to look at it. And the grid lines looked all wavy, and the black dot in the center I couldn't even see. And that was the first indication I had.
When I see patients who have either AMD or DME, at this point what I'm really thinking about is looking at and understanding what fluid we're talking about in the macula. So we're going to be doing macular scans. So when I have somebody who's coming in who is diabetic or has a history of macular degeneration, that's going to be step 1 for me as a generalist, is looking to understand really what's there so that I can then decide if it's somebody who I can keep to continue to just monitor, or if they need more specialized care with one of my retina specialists.
The standard of care for somebody who has macular degeneration initially is the dry, mild form of macular degeneration. Those patients are encouraged to take their antioxidant vitamins, to avoid cigarette smoke, to wear sunglasses, to have a good diet. However, that may convert into the wet form of macular degeneration, called so because it starts to leak or bleed. Leaking and bleeding in the back of the eye can cause devastating vision loss. In fact, wet macular degeneration and macular degeneration generally are the #1 cause of vision loss in our elderly patient population in the United States of America. Standard of care when they start to have leaking and bleeding in the back of the eye is to very promptly initiate injections with anti-vascular growth factors, medicines that are placed in the eye to reduce the leakage and the bleeding. There is somewhat of a knowledge gap that's present in the treating population for our patients with macular degeneration and with diabetic retinopathy, despite the best efforts of well-meaning and good doctors around the country. It's very difficult if you're not involved in clinical research, if you're not involved in the tip of the sword, to really stay abreast of all of the treatment options that are available, because they are myriad for both macular degeneration and for diabetic retinopathy. We have been treating these diseases for decades, and the new anti-vascular growth factor and dual mechanism of action, stronger, longer-lasting medications, those are changing the entire treatment paradigm.
My wife took me in to see the ophthalmologist that we always go to see, and she told me, after examining my eyes, She told me that I had wet macular degeneration in my left eye, but she said, you have a bigger problem in your right eye. She says, you have a horseshoe tear in your retina in your right eye. I got in to see Dr. Graff the next day, and they took all sorts of tests and photographs and stuff. And when he came in and sat down, he introduced himself, and he says, we can take care of the wet macular degeneration in your eye. He says, I'm going to give you a shot in your eye right now. And I figured, well, great, that's going to really feel good. It doesn't hurt at all. And they use this tiny, tiny little needle. And he says, now we're going to fix your horseshoe tear in your retina in your right eye. And he gave my wife a pair of very dark glasses, turned the lights off in the room, and he says, don't close or move your eye. He says, I'm going to fix that tear now. And he says, it's going to be a real bright green light. And it was, and you could hear it was kind of buzzing, and it was like he was welding. And about 30 seconds later, he says, we're done. And each time I go in, he checks my eye for that, and he says it's doing good.
Dallas presented with decreased vision and blurring and smudging with distortion in his central vision in his one eye. He noticed the symptoms, he was aware of that. Initially, you get in first to a comprehensive eye doctor who confirmed fluid in the back of the eye and promptly got him into me. When we saw him same day of diagnosis, we did high resolution imaging, examination, confirmed wet macular degeneration with fluid and blood in the retina and decreased vision as the source of his symptoms. We immediately, same day, began treatment with medication in the eye, anti-VEGF medication. Traditional anti-vascular growth factor treatment, or anti-VEGF treatment, has been around for 19 years. We're coming into the 2-decade mark of treatment. And traditional treatment was a game changer in both diabetic retinopathy and in macular degeneration. We were able to not just stop devastating vision loss, but turn back the clock, restore vision in many cases. However, the traditional anti-VEGF therapy has its own limitations as well. The first-line medications are not FDA approved for use in the eye. Bevacizumab is never intended to be injected in the eye, and yet we do that frequently in an off-label form. So then you go into these next-generation on-label FDA-approved medications, and the first FDA-approved on-label medications like ranibizumab and first-line aflibercept were the next step forward, where we now have it approved, packaged, and prepared for the eye. The preparations are easier, better, pre-filled syringes, and the medications have now data behind them specifically for use in the eye. In the Pulsar and Photon trials, these trials allowed us to see the response to high concentration, 8 milligram aflibercept. And we see that in wet macular degeneration and diabetic macular edema, respectively. Similarly, we found that the patients were able to have a much more durable response to the medication using the high concentration of aflibercept, with less leakage or fluid recurring, maintenance of good visual acuity, when compared against the lower concentration of aflibercept, the 2 milligram, which we had previously used for many years. We found that over 3/4 of the patients were able to go out to this 12 to 16 week window in between treatments. These increasingly durable medications allow us to reduce the treatment burden on the patient with very good response, and the studies have borne that out.
You know, I think back to residency, and I think back to what I learned as a resident. We didn't have any pharmacological treatment aside from something topical like a ketorolac. Those were the days when laser was the common modality that we used to treat these patients. And what's so wonderful about the world that we live in is that we are continuing to evolve with different options. And that evolution has led now to using injectables as anti-VEGFs. Those anti-VEGF injectables have really changed the game for all of these patients. I think that we as a community of ophthalmologists are so much more keen on using these pharmacologics because they've done such a good job at helping reduce a lot of the visual burden that people have.
If we were to reflect on the Yosemite and Rhine clinical trials, which were the landmark trials in wet macular degeneration that led to FDA approval of faricimab, we see another game-changing event that took place. This led to the FDA approval and the wide adoption of faricimab, a dual mechanism of action. It blocks both VEGF and angiopoietin-2, allowing a more durable control of the disease and also showing great efficacy at reducing fluid, which of course is our goal in wet macular degeneration. About 3/4 of the patients were able to get out to 12 weeks of therapy in between, and about half of the patients extended out to 16 weeks in between treatments, allowing similar outcomes to every 4-week injections of ranibizumab.
I was getting the shots once a month. It cleared up the waviness in my vision, and it cleared up any leakage from the blood vessels in the back of my eye. Dr. Graff told me that it was completely stopped, and I asked him how long I would have to get these shots, and he said the rest of my life. My wife and I like to travel a lot, and having to go in once a month and get these shots, it kind of limited the travel that we could do because we had to be home for appointments. So it tied me up once a month for the rest of my life.
The motivation for shifting from an injection paradigm to a continuous delivery paradigm was really twofold, as I think it is really for most of our patients. Number one, continuous disease control, continuous pharmacokinetics instead of episodic pharmacokinetics. And number two, decreased burden for the patient and his family. Dallas and his wife love their life together. They love this sweet time they get together. They like to travel. They like to spend time with family. Studies have shown when you truly interview a patient, the burden of coming in for an injection is many more hours than the time they spend with you. Their day is kind of shot. Their vision's blurry, a little scratchy. The eye can be irritated. They sometimes go home and rest and take a nap, traveling to and from, preparing for the injection. So it's not just the burden of the hour or two they spend in clinic getting their treatment.
The limitation of what we consider to now be traditional therapy, which is injectables that are done in the clinic, is that patients have to continue to come in, and some of them quite often, 1 month up to 3 months that patients are coming in for repeat injectables. That's really hard for patients. It's hard to get them to have compliance, right? We all have lives, we have other things happening. In addition, it's really hard on the clinic and the clinic staff and the physicians. I mean, there's only so many of us, and that treatment becomes, very honestly, can be a burden. So there's other options, which I have been privy to work with Dr. Graff with, including a portal delivery system. And that's going to be fantastic, right? For not only the patients, because they're not going to have to come in as often, but also for the physicians and staff, and the burden generally to the system on the number of people who are going to need further treatment and assistance, because this isn't just a one-time therapy, but an ongoing treatment.
When Dallas and I talked about a continuous treatment paradigm, for the two reasons we mentioned, he was very interested in that. He asked very intelligent questions and thoughtful questions about how this would work for him. He was well informed about the post-surgical change and watching him for a few weeks until he had recovered. So it was to provide continuous disease control and reduced burden on he and his wife. And so that led to him getting the implant a little over a year ago.
Dr. Graff explained to me what the shots would encompass every month, and he was looking for other treatments for it, and that's when I got the implant. It was a very smooth procedure. It was under anesthesia. I remember it was probably more of a twilight sleep. I remember when he put it in, and he had a couple of people in the operating room with him, and he explained all of it. And I remember all of that. And then the implant was pre-filled. He had me come in about every 2 to 3 months before I got the first refill, just to check everything and make sure everything was doing what it's supposed to do.
Dallas's response to the implant is not only A, optimal, but B, very consistent with what I see all the time. I have currently well over 100 patients who are coming back periodically for a refill of their implant, a refill exchange, just like we do now in the studies every 6 months, and in the clinical trials and real-world trials like the Summit clinical trial, we actually find the patients approaching more like 8 months in between the refill exchange. And that's what we see with Dallas. After the surgical procedure was done, he healed up beautifully. There was no recurring fluid. It was 6 to 7 months later, last summer, we did his refill exchange. And now it's been another more than 7 months, and there has been no recurring fluid. His visual acuity is 20/30. The disease is beautifully controlled, and we will plan in the very near future to do another refill exchange.
I continue to see treatment and management of disease improving, especially as the years have really gone on, as we've gotten better at what options we have available for patients with AMD and DME. And this really, a lot of it comes down to the pharmaceuticals as they continue to evolve, and the ability for some of these pharmaceuticals to give us more time or break in between injections, where patients can actually go for several months or maybe even longer without needing repeat treatment. And that really makes patients happier. They like to see us, but they don't like to see us that much. So taking that time to be able to say, hey, we've got a couple months of a break, it makes a big difference. And so I've seen patients who are feeling much more calm and at ease about the idea of how much regimen or treatment they need to keep coming back for, especially as that gets spaced out and extended.
I was just concerned about getting the implant, what it would feel like, or how long I would be disabled or whatever, but none of that came true. Dr. Graff has done this before, and he assured me that it would just be a very fast procedure and I wouldn't have any after effects. I think the implant has been the best thing that I could have done for what I had. It has improved my life in that I don't have to go in for shots anymore, that I just go in for refills of the implant every 6 to 8 months.
With regards to the complications of the port delivery system, we have been very tuned into that as investigators and as a retina community. In the wet macular degeneration trials, specifically Archway, which led to FDA approval of the port delivery system for wet macular degeneration, we saw about 5% of vitreous hemorrhage and a few percent of conjunctival erosion or retraction, leading to a 3-fold increase of endophthalmitis compared to the injection arm. So we were watching in the later trials a couple of years later in Pagoda and in Pavilion to try and reduce those complications. And in the first year of the Pagoda and Pavilion trial, we saw 0 cases of endophthalmitis, and even fewer cases overall by the end of the second year, where we saw the endophthalmitis rate drop from over 2% to just barely over 1%. And so that's very encouraging for us to see fewer examples of endophthalmitis. We saw fewer examples of erosion and retraction as well. But those kind of things, we still want to see those numbers drop even more. There are ongoing trials worldwide to try and investigate macular degeneration treatments with the port delivery system in other countries around the world. And we are seeing reduced complications in those trials now.
I would tell other people that have this condition to get the procedure done. I've talked with several people that have wet macular degeneration, and I've told them about my procedure and told them that they ought to see their retina specialist and talk to them about it, because this is something that can save your eyesight.
There are non-pharmacologic treatment options available to patients with wet macular degeneration and with diabetic macular edema. In fact, many of those predated the pharmacologic injection treatments that we have currently. Laser still has a role to play. Angiographic analysis can show us very distinct lesions that are leaking and bleeding under the retinal tissue, some of which may be amenable to using a PDT laser, a photodynamic therapy laser, or even an argon laser if it's out away from the center of the retina and it's recalcitrant to medication. So those options are still available. But the pharmacology is really where things have shifted over the last several years. If we are looking forward, this is an exciting time to be a retina surgeon. This is an optimistic time to be a retina patient, because the next generation of therapies include potentially tyrosine kinase inhibitors, further reducing the burden and using a different mechanism of action. Potentially we have the port delivery system already FDA approved, but as a platform there may be other molecules that could be placed in there, increasing the durability. I'm involved in the gene therapy trials, And there are 3 major gene therapy trials going on right now in phase 2 and phase 3 that hopefully will give us an opportunity to create intraocular biofactories where we can use gene therapies to teach the body's cells to make the medicine that we used to have to inject. That's very exciting as well. So that's what's coming down the pike in clinical research and the transition, what's going forward, that will reduce the burden and provide that continuous delivery of medicine instead of episodic delivery of medicine. Patient compliance to the treatment paradigms that we propose and helping them adhere to the treatment schedule is one of our primary foci. We are trying to help the patients knowing that they have other issues. It's not just, sometimes when we say compliance, we're implying that the patient's not doing what they should do, when in truth, compliance is a whole host of other issues. There are transportation issues. Their granddaughter who closes their law practice for the morning to be able to drive grandma in, or somebody who has difficulty with going across weather issues, traveling great distances to find a retina surgeon. They may have other medical issues as well, other calendaring challenges with their nephrologist and their cardiologist and their neurologist and all sorts of other medical appointments they have. Additionally, especially in our diabetic patient or in our elderly population, they have other illnesses, hospitalizations, and they miss an appointment. How do we help with that? We help the patient to be able to get access to the best, longest lasting treatment options available so that the burden on them coming in for treatments is less.
Strategies to try to help keep patients motivated, especially when they're going through multiple rounds of injections. The biggest thing that I think personally I like to talk about is actually looking at the physical evidence of improvement. I think that's where people start to feel very motivated about continuing their care, because sometimes they feel discouraged when they feel that the vision isn't as good as it used to be in the past, or even that it's just not improving as rapidly as it once was at the beginning of treatment. And so I like to just go back and look through OCTs and really show what we're talking about in terms of improvement in the quality of what the retina looks like and the pathology. I remind them that this is something that can potentially return if we don't continue on the path of treatment that we've already started, and to remind them how important that is and that we don't want to lose any more of that precious retina. And sometimes if we wait too long or if we skip too many treatments, we can start to have scarring and we just can't return from that place. And so that seems to be a way to keep people motivated, is really education, which is understanding what we're doing, why we're doing, and the importance of continuing to do what we're doing in terms of treatment.
With regards to the patient selection, not everybody is a candidate for a gene therapy in clinical trials or for the port delivery system, which requires a surgical implantation. Not every patient requires it. They may be able to go out to 16 weeks in between injections. But even patients who require more frequent injections, who have a hungrier lesion that requires more assertive care, more frequent treatment, even with the best medications available, they have to be able to follow instructions postoperatively, return for postoperative appointments, be healthy enough to undergo a surgery. They have to be able to have healthy conjunctiva and not have had other glaucoma surgeries. So not everyone who I think would benefit from the port delivery system is going to be offered that surgery. So selecting the right patient population, either for the medications we're giving or for the surgeries we have to offer, is another consideration.
Dr. Graff is an amazing person. He spends all the time with you that you need. He doesn't seem like a doctor. He seems like a friend. He's just an amazing person, and once in a while he'll tell you a story about when he was in medical school. So I believe Dr. Graff could probably do anything with the eyes that he needed to do.
With regards to my patients, I feel such a great sense of gratitude, responsibility. I think good doctors have an overdeveloped sense of responsibility. The patient matters more than anything else. Personal time, other commitments, your schedule, your day, your lunch, or whatever. Your patients need you. And I feel a great sense of gratitude of my patients trusting me. They are dealing with some difficult things, whether it be macular degeneration or diabetic macular edema, or any number of other conditions that I treat. And I'm very grateful for their trust. I don't take that lightly. I take that responsibility as something that I want to make sure that I always live up to their expectations, their hopes, that I am going to provide the very best care that I currently can for them, including the best medications, the best treatment options, potentially new treatment options, giving them opportunities to participate in clinical trials. That's something that I hold as a great responsibility, and I'm very grateful for and humbled by that responsibility.
If I were to lose my vision, it would be devastating, I think, because there's so much beauty around me that I like to see. I like to see my wife. I like to see all my kids and my grandkids, and I can't even imagine losing my eyesight. It's something that a person should have all of their life.
Please don't forget to utilize the point-of-care tools, such as the personalized poster portal animations, the web portal, which are available to you on demand at any point. These tools have been designed to support reflection and translation of your knowledge gains into practice. They've also been designed to be used in practice with your patients to improve communication and help your patients and caregivers understand complex information about their disease and treatment options. Thank you again, one and all, for tuning into our program. And we hope that you've taken away some valuable lessons to incorporate in your patient care journey. Med Learning Group looks forward to your participation in future events and appreciates all that you do for your patients. Please remember to complete your post-test and your evaluation and attain your credit for attending. Finally, don't forget to use the tools we've developed with the program chair to assist you in your practice. This is Jane Seymour, wishing you and your patients the very best. Be well and take care.